So I will start my part. Let me see if I can share screen here. Okay. Okay. We're going to be short on time, so I will. How do I advance this one here? So as Dr. Bell mentioned, really for oral cavity surgery really is a primary modality. So for the most part, radiation for oral cavity cancer really is in adjuvant setting. So I'm going to talk about adjuvant radiation therapy a little bit and how we do it, why we do it, and is there anything we can do to reduce the toxicity or complications? Hopefully we can preserve patient quality of life. So as far as oral cavity cancer treatment guidelines, again, for early stage, surgery alone may suffice. For patients who cannot have surgery, the primary radiation therapy occasionally it can be used successfully. Now, for the most part, radiation therapies in adjuvant setting for large tumor, for patients with adverse factors such as positive nodes, PN9, peritoneal invasion, lymphovascular space invasion. Obviously, when patient has a positive margin and actual nodal spread, like chemoradiation therapy would be necessary. So this actually shows the benefit of a post-op radiation therapy. If you focus on the bottom row here, so basically, I have a few literature I have to share with you in a minute, but this shows post-op radiation therapy versus surgery alone. For intermediate risk patients, the benefit is about 30% in disease-free survival and about 10% in overall survival. So really, there's potential survival benefit. Now, for more advanced stage cancer, high-risk patients, such as positive margin and E&E, or locally advanced stage, large T4. So the benefit of a post-op radiation therapy is more profound, and 28%, almost 30% chance in overall survival benefit, and 42% and 45% chance of better local regional control. So you see clearly, radiation therapy has a benefit. And so let's go over now. For low-risk patients, surgery alone usually suffice. So, but the interesting thing is that how we select those patients is considered true low-risk patients. So I'd like to share one study, which actually is the largest study looking at this aspect for patient has clinically a T1, T2, and 0 disease, had a resection and a negative dissection. So the pathologically in 0 disease. So even for those patients, again, if there's any adverse features such as coast margin, lymphovascular invasion, peritoneal invasion, those patients actually will get radiation. So the group patients we're looking at the T1, T2, and 0 disease truly is low-grade, low-risk patients. But if you look at the low-risk patients without additional treatment, so the risk of recurrence, the local recurrence, is 10%, and 18% patients actually develop regional recurrent disease. And 1/3 patient actually recur. Actually, 1/3 patient recurred in contralateral neck. So that shows that for some patients, we really have to consider adjuvant radiation therapy, even they are considered low risk. So if you break down the study, really the patient has thicker tumors, especially thicker than 4 millimeter. So those patients have much higher risk for failure in the neck, and so those patients we should consider adjuvant radiation therapy. Now move on to intermediate risk. So that is the T1, T2, and 1 disease. One patient has a single lymph node. Those patients can be observed, and also in general, we'll tend to recommend radiation therapy if there's any other features, intermediate features like peritoneal invasion, in addition to one single lymph node. But this is a study that came out about 2-3 years ago, looking at this T1, T2, and 1 disease group, which is intermediate risk. So the bottom line is that by adding radiation therapy, there's a significant benefit in terms of overall survival. So this is for patient has T1N1 disease. And if you look at patient T2N1 disease, the survival benefit is even more profound. So both are statistically significant. So this shows the benefit of adjuvant radiation therapy, even in for low risk or intermediate risk patients. So the benefits of radiation therapy really is because improved the disease progression-free survival and overall survival. So how we should do it, radiation therapy. Now we know IMRT, which really is now standard modality, radiation modality for head and neck cancer. We know IMRT provides excellent target coverage and the normal tissue sparing. So the most important thing when we do IMRT really is how accurately we can define the targets. So if you miss any a disease, no matter how good the IMRT is, you're going to fail. And so we know there's actually quite a variation among physicians in defining head and neck cancer volumes, which is expected. So we do have guidelines to follow. This is a consensus from URTC, RTUG, and the GORTAC group. So they tell us how to define the regional disease, actually regional lymph nodes from level 1 through level 7, depending upon the primary. So at different primary sites, you have to select the lymph node coverage differently. So one thing is sometimes we may struggle. So for smaller lymph node, whether we should consider add those lymph node to the GTV, the gross tumor target, so or not, or make this microscopic disease. In general, if the tumor is larger than 1 cm, or 1.5 cm for the level 2 jugular digastric lymph node, or sometimes you see a necrotic center or it's round a cluster, and so this lymph node, and even though PET is negative, but this lymph node shows some characteristic for pathologic lymph node, so we'll cover those as a gross target. Share one case, the patient T2N1 disease, the lateral oral tongue, so had as expected, the partial glycectomy, lymph node dissection. This is what pathology showed. It's a T2 because 2.5 centimeter, the depth invasion is 10 millimeter, margins clear of one single lymph node without ECE. So how I do it? So basically, we define the CTV, clinical target volume. CTV1 is considered a high risk area, so really is a surgical bed. So I define that surgical bed at first as a CTV. Then you define the CTV2, which is a high risk area around the tumor bed around CTV, and also ipsilateral neck. So this is considered as a CTV2. And then the contralateral neck is defined as CTV3. Oftentimes you have to expand the field to cover the surgical bed. This is surgical scar right there. So once you define the volume, then you can prescribe those differently. So for the high risk area CT1, you give 63 in 30 fractions. Then for the high risk neck, you give a 60 gray in 30 fractions. The contralateral neck is a 54 gray in 30 fractions. So you can see we can do dose painting. We can deliver those different dose to different areas depending upon tumor burden. So this is what we actually normally see as the final treatment plan. Look at dose distribution and also look at the normal tissue sparing. So this is the general definition of a CTV1, CTV2, and CTV3, and also we add about 3 margin as PTV, the planning treatment volume. What about the toxicity? This is the part we like to focus on. And we know radiation therapy is effective. Radiation therapy has a very good chance to, especially for microscopic disease, we have a very good chance to eradicate microscopic disease. But unfortunately, radiation therapy has significant side effects, especially for head and neck area. Acute toxicity, unfortunately, is not avoidable, like radiation dermatitis and mucositis. But oftentimes, that's transient and it will go away after you're done with radiation therapy. Now, late toxicity is something we try to minimize, such as xerostomia, for instance, dysphagia. We have next talk actually specifically on dysphagia, the dental decay, fibrosis, and also complications such as radiation, the osteoid necrosis, radiation neuropathy, brachial plexopathy. The worst case will be spinal cord injury, and also radiation infection on carotid can cause stenosis and can cause a stroke. So that's complication. We have to try everything we can to minimize. So what are those factors for radiation toxicity? We know the radiation dose matters, right? The higher dose, the higher risk, and also fractionation, how much dose we give each time, and the radiation field size, radiation volume. So those are major risk factors, I should say major factors for radiation toxicity. And then also there are patient-related factors such as a smoking history. We know patient has has a significant smoking history. Those patients at a higher risk for radiation complications. Diabetic patients also has higher risk, and a certain genetic syndrome can increase the risk of radiation complication. And also normal tissue sensitivity, radiosensitivity. Some tissues are more resilient, more resistant to radiation than others, but some tissues are highly sensitive to radiation. Obviously, the most critical structure for head and neck cancer radiation treatment is the spinal cord, and so that's and of course optic nerves. If optic chiasm, those areas are very vulnerable to radiation. So of course, if a patient is getting concurrent systemic therapy, those patients also may be at high risk of acute radiation complications. Now, the simplest way and the most important way really to minimize toxicity and complication is to deliver radiation with the precise targeting, and also the timing, and to avoid unnecessary overtreatment, especially if you can avoid treating large volume or higher dose. You should do that, provided you're not going to compromise the chance of a cure. So a couple of examples show the better radiation technique does improve the better outcome in terms of functions, quality of life. One thing is to look at the parotid. So basically, this study look at the IMRT versus 3D, and clearly, the IMRT has a much better chance to spare parotid, even in long term. And so this is also look at the radiation fibrosis. So clearly, if you can do more normal tissue sparing with IMRT, you have a much better chance to avoid or minimize the severe fibrosis after radiation therapy. So what about post-radiation dysphagia? This is a major problem we're facing, because nowadays we have a lot of HPV patients that are young, they're healthy, they have a highly curable disease, they're expecting, we're talking about the expected survival is decades and decades. So that's why the long-term effects of radiation therapy, especially on patient functions, quality of life, is very important. One major thing is dysphagia. I know Carol actually will be talking about dysphagia post-therapy, not only necessary radiation, but surgery as well. And also, there's a study looking at the what affect patient the most in terms of quality of life. Turns out that dysphagia is more important than xerostomia and more important than radiation fibrosis. So how can we reduce the risk of radiation-induced radiation-induced dysphagia? Really is a strong correlation between the dose and also the pharyngeal stricture muscles. And of course, the dose to the larynx, esophagus are also very, very important. So important thing is that you try to minimize radiation dose, such as mean dose to the larynx to less than 50 gray, and the mean dose to the pharyngeal stricture muscle to less than 50 gray, because nowadays we use a 45 gray mean dose. And also you look at the 50 and the volume receive 50 gray, 55 gray, 60 gray. So bottom line is that if you can, you really should try everything possible to minimize radiation dose to the pharyngeal strictures. So if you look at the current clinical trials, that tells you how to prioritize your volume when you do IMRT. So obviously, spinal cord has the highest priority, brainstem has highest priority, then the treatment target. But the pharyngeal, the constrictors really has a very high priority. It's number 6, even higher than esophagus, higher than parotid. And so which means that you really have to try everything you can to spare the pharynx. So the dose now we use the 45 gray, and also you try to avoid high dose to the larynx at the same time. So this is what I do. Obviously, you outline the constrictors all the way from oropharynx to hypopharynx there. And also you contour the larynx. So try to spare that both structures as much as you can. So when you have a radiation apply, you can see how well you spare the constrictors, how well you spare the larynx. So make sure you can protect those structures to minimize radiation induced dysphagia after therapy. One thing I also want to mention is the technique. Like, let's say do radiation therapy for oral tongue cancer, for oral cavity. The bite block actually is very important. You use bite block to displace the tongue, displace the jaw away from the hard palate. So this will, when you do the radiation, you can substantially minimize radiation therapy to upper oral cavity, reduce not only potential long-term artifacts, but also acute side effects such as mucositis. So another thing is that when we do the planning, oftentimes we see a lot of metal scattering because of dental filling there. So with the new software, we can reconstruct it, the CT scan, to clean up the scatter effect, and it's a bit easier for target delineation. So this is a very interesting case. I mentioned the patient may have dental fillings there and the crowns there. So that really scattered radiation can cause substantial focal radiation mucositis, like this case, because dental filling. So how we avoid that? We know the radiation scattering doesn't travel very far. So if we can create some space, small space between the teeth and the cheek, or between the teeth and tongue, you can actually substantially reduce the scatter effect. So one thing I would do is use, most patients will have a fluoride tray made by our dental oncologist to apply fluoride after radiation. So that tray is quite thick. So you can ask patient to wear a fluoride tray for the radiation treatment. So you can see this patient has quite a bit dental. This is his dental artifact. You can see with the fluoride tray, you can create the space and to really minimize the radiation scattering to the bulk mucosa and even to the oral tongue, because you can see the space there. So your patient has a fluoride tray, your patient has an extensive dental metals or fillings there. It's always better as patient to wear the fluoride tray to come back scatter. So this patient, see without fluoride tray, you don't see the space. So this actually is very helpful to reduce acute mucositis. So in summary, we know adjuvant radiation therapy really is important in management of oral cancer, oral cavity cancer, actually head and neck cancer. So MRT really is the standard and preferred form of radiation for all head and neck cancers. It is important to be able to precisely define the targets, and also to be able to define the critical structures to spare. So I really think it's important to introduce more stringent dose constraints for normal tissues of interest, such as the parotid, the larynx, pharyngeal stricture, which may eventually lead to less late toxicity. So that's my presentation. So our next speaker is Carol Gibler. She is actually a speech pathologist.